Hi, I'm Dr. Michael DiTolla, and I'd like to welcome you to this presentation from Glidewell Laboratories. Today we have a guest with us, Dr. Todd Morgan from Encinitas, California. Welcome, Todd. And I brought Todd in because I want to talk to him about incorporating snoring and sleep apnea into the general dental practice. Todd and I had the opportunity to practice together for a number of years, and while I was there, I saw that about 50% of what Todd did was obstructive sleep apnea type treatment, in addition to the other 50% that was restorative dentistry. And as a restorative dentist myself, I noticed something. I noticed that the work he was doing on the sleep patients looked to be a lot easier, if you will, at least not as physically demanding as the restorative dentistry that he and I were doing together. So I wanted to bring him in and ask him some questions because I get a lot of questions at my lectures and emails coming into me about I'm interested in providing this type of service for my patients. What's the best way to get started? So again, welcome, Todd. Thank you so much for being here.
Thanks for having me here. Appreciate it.
When you and I practiced together, the sleep portion of the practice, I think, was about 50% of what you were doing, and this probably goes back about 10 to 12 years ago. Where is it now? Is it still 50-50 between sleep and restorative?
Yes, it is. It's still about 50-50. Both the dental practice and the sleep practice have grown. However, the dental practice, not as much nearly as the sleep practice. That's really taken off for me. So even though it's about 50-50 in terms of the patients and appointments, really the sleep practice is a little more profitable for me
than the restorative practice. That's interesting. Now, when you went to dental school, were you exposed to any of this stuff? I know that when I went to school, this never came up. In fact, I didn't even know about it really until I met you. So how did you get into it? Was it something you were exposed to in school, or was it?
Absolutely not. I mean, just like you, I wasn't trained in this at all. I accidentally discovered, basically, heard about anecdotal reports of a gentleman, Dr. Mead in Albuquerque, that was making snore guards, and I wasn't busy. I hung out a shingle. I mean, I didn't buy a practice, so I started out a little bit slower than if you had bought a practice. And so I read a lot. I read every journal. I read everything and saw a little anecdotal report. And I went out and visited him, and he showed me what he did. And basically, I looked at it, and it looked like two night guards glued together with a little insert that held them together. And I said, you know, I could do that. And my dad, who was a champion snorer, I think they call him stentorian snorer. I mean, you could hear him down the hall in the next house. The neighbors would call, you know, hey, roll him over. But I tried one on my dad, and it was so remarkable that he instantly stopped snoring. My mother was so worried. She sat up all night for several nights wondering if, you know, she was so used to the noise, she said she couldn't sleep anymore.
Right, she had to start a chainsaw now in the background just to fall asleep.
Yeah, but you know, I have 4 brothers, and we were always in trouble, and no sisters, always in trouble, and he was like the authoritarian of the family. And we were all afraid of him, and he was this mean guy, and you know, all of a sudden he turned into this guy that was cool. He was nice, he wasn't grumpy anymore, and so the change in him with his snoring, but also the personality change. He was getting rest, and now he was a different man. And that was so incredible for me that I knew I was onto something.
And so when you first saw this appliance, you said you read an article in a journal that showed it?
I just read an anecdotal report of one patient that he had published, and thought, you know, my dad was snoring, and so I went and checked that out.
Is that really the thing that got you to go? Was
Yeah.
that you knew your dad had this condition and that you might be able to do something
Well,
about
I knew
that?
he snored, and
Right.
really they didn't talk about sleep apnea back then with oral appliances. This is 1988. And so I dabbled a little bit, and I used the skills I knew. Take a night guard, and we know how to fit splints,
Right.
and glue them together and put them in different places, and I did that for years and years, and treated more and more patients. And finally, I took the idea to a sleep lab in San Diego called Scripps Clinic, and one of the docs said, hey, let's try some of them. I just had the right timing in the right place. And after that, we published some results on 20 patients with full sleep studies, and we were curing sleep apnea with these appliances.
And was this the first time, does this mark the beginning of oral appliances being used? I mean, traditionally, what did they do for patients with sleep apnea?
Oh, they've always used what's called CPAP, continuous positive airway pressure machines. The machine's basically a vacuum cleaner in reverse that you strap onto your nose and pumps air in, inflates the pharynx and keeps it open at night. And that's been the treatment of choice ever since it was invented in 1982. That was an Aussie named Colin Sullivan out there that invented that. And so that works, and it still works. That's still the #1 prescribed treatment. There's been a few changes in the technology since then, but that's still the #1 treatment. There's surgery that's done occasionally. Oral appliances kind of belong second to CPAP. You really don't want to go to surgery until you've tried the non-invasive things first.
Right.
In patients.
And so the CPAP is the one. I was flying to a lecture the other day, and I saw somebody take out a box in the security line. I guess you can't just x-ray this in your luggage, and they had to take it out and bring all this thing out. And it looked like a machine, I guess, about the size of this, with a mask that straps onto your head.
Right, and you're not signing up to be the co-pilot. That's a CPAP machine.
Right.
That, and they're cumbersome to travel with. I have lots of patients that get an oral appliance just for traveling. They like their CPAP, they use it at home, but that's just one application of having an oral appliance for a patient.
I sleep on my stomach, so it doesn't look to me like there might be a way that I could actually wear a CPAP. So if I had a snoring problem, and I actually cured my own snoring, or maybe I had a sleep apnea problem, I lost 65 pounds a couple of years ago and it stopped. So we'll get to how weight loss fits into this later, but it does sound like, for me, somebody who sleeps on their stomach and wouldn't be able to wear a mask or tolerate a mask, that an oral appliance might be the way to go.
Yeah, exactly. And at least half the patients that start pressure therapy with the machines abandon that down the road. Most of them pretty quickly, and then a lot of them later down the road. And so there's a huge demand for oral appliances for those patients. If you only made appliances for patients that couldn't wear CPAP, that had already been diagnosed, and you had a relationship with a physician, a sleep doc, or a pulmonologist, someone that prescribed those, if you only treated those patients, you'd have tons of patients to treat. There are so many of them.
So in a perfect world, everybody would be able to tolerate CPAP and wear it, and it keeps your airway open and does all these great things. But the reality is a lot of people can't handle this and need some sort of alternative, and it turns out that dentists can fabricate these appliances and give them some help.
Yeah, that's right, and there's lots of patients that need help. You know, I'm a CPAP fan. I mean, it's the #1 treatment. It's the most robust and effective treatment out there, and I'm all for it. You know, the worst thing you can do is not be a PAP fan in terms of your relationship with the physicians. I mean, you're a PAP fan first, and then oral appliances, you're there to help out those patients that can't use it.
Right. So this is a field of dentistry where you are, by definition, going to have some interaction with some local medical personnel, some local doctors. It's not, well, it's kind of like, you know, the way that we have a relationship with an oral surgeon or an endodontist, although we decide, you know, when we're going to send that out. But because this is truly a medical condition, it sounds like, as opposed to a dental condition, it sounds like you're going to need to have relationships with some of the sleep doctors in your community.
Yeah, and it's a little bit outside the comfort zone for a dentist. I mean, we know how to relate to specialists within dentistry. Really, it's easy to develop a relationship with a physician, and they want that relationship too. But you have to step outside your comfort zone a little bit and go meet the doctors and talk to them. But the point is that they are looking for us to help their patients as well. And if you can establish a relationship, you're going to have lots of business for oral appliances that way.
Any idea if physicians, while in medical school, do they see a lot of this? Are they educated about obstructive sleep apnea? Or?
What I've heard is that there's very little training in sleep for medical students. Basically, you graduate medical school, you go through your residency, and then finally when you begin to specialize, and usually pulmonologists, you know, breathing, all that, then you begin to specialize in sleep. So there really aren't a ton of sleep specialists out there. In LA, San Diego, there's lots of them, but there really aren't a lot of sleep labs in rural zones. And then you have to team up with a primary care doc. They all understand sleep apnea. It's so prevalent now and so dangerous. But it is a medical disorder, so the dentist has to put on a physician hat, if you will, and understand the medical part of that a little bit to do the treatment effectively. And of course, it's reimbursed through medical insurance. And so it's another example of that might be the maxillofacial prosthodontist, restoring cancer, lost a nose or ear or some structure. So really you're doing a medical treatment for that patient too. And dentistry crosses over in medicine a lot, and we really shouldn't be separated as we've always been.
Right.
I think we're just a specialty within medicine.
Because it's really unfortunate that you've got all these patients falling through that crack, like your dad, who's not getting treated by maybe his primary care physician or his dentist, because neither group has really been educated about it. And so you got this large group of people who are suffering with something that sounds like a chronic progressive disease, a little bit like periodontal disease, where it tends to get worse as time goes on, and no one's really stepping up to help these patients. And I know a friend of mine who's a consultant whose brother died from sleep apnea. I mean, people do die from this, right?
They do. Yeah, you're right. Sleep apnea is a progressive chronic disease, just like diabetes, periodontal disease. It will worsen with time and with age. There are exacerbating factors like obesity, other things that add to the problem. But you're really treating a chronic disease, and the patient needs to be managed, just like periodontal disease. You see the patient every once in a while, clean their teeth, do all that. Well, you need to follow these patients along too. And most of them fall into treatment, they do very well, and they just need to be checked periodically. And that's really part of the responsibility you're taking on. It's not, here's your appliance, goodbye. And there is reimbursement for all that follow-up. It's not like you're not able to charge, for example, to follow the patient and take care of them along the way. And you're really partners with the physician in that role. You and the physician are partners, following this patient through time and managing their disease. You're seldom curing the disease.
Right. Well, you don't cure periodontal disease, do you? I mean, you manage it and try to keep the teeth in the patient's head until they
You might have been a cure
die.
with your weight loss, though, for example, or surgery can cure a patient with sleep apnea. But oral appliances are a treatment, ongoing treatment like CPAP is.
Right, okay, that makes a lot of sense. So when you get a patient, well, if you look at the laboratory, if you look at what we do, we've made over 70,000 silent night appliances. A lot of them have been for single doctors. Well, we made one of them, and they haven't done another one since. And yes, that's always been our feeling. When you pull up the prescription, the doctor's name and the patient's name are exactly the same. And so you realize the wife has threatened maybe to leave the bedroom or the house or the marriage if the dentist didn't make a silent night for themselves. So I think one of the things that dentistry has done is that a lot of our dentists look at snoring as something that's just kind of an annoyance and not a big deal, and almost something that society makes jokes about. And then you have sleep apnea, this chronic progressive disease that can lead to death and stroke and high blood pressure and all this other stuff. But we can tell just by the number of appliances that we've made, the number of snoring appliances we make here versus the sleep apnea ones, that most dentists are kind of focused on that. And that the snoring, the treatment of the snoring probably doesn't seem like real dentistry or the ability to really have an impact on a patient's life, whereas the apnea is more important. So right before we talk about how you bring a new patient into your practice and differentiate what they have, talk a little bit about the difference. You mentioned your dad already and just the huge change in his quality of life. What do you see for most of these sleep apnea patients when you make an oral appliance for them and they start to experience, being able to breathe throughout the night?
Sure. Breathing is cool. If we back up just for a second and we talk about the dentist trying an appliance on themselves, treating a dentist with an oral appliance, they're the worst patients.
Really?
As soon as you try it in and your bite feels off in the morning for a little while, it's like you freak out.
Right.
So don't try it on yourself, first. But back to your point, I tell people that ask me, dentists that ask me, this is one of the most rewarding things I've ever done. I spent my early years lifeguarding in San Diego on the beaches and literally saving lives, and that was very cool. Fortunate to do that. And now I'm doing it again, literally saving lives by getting people treated for sleep apnea. Their breathing, the significant comorbidities that take place when you strain the heart at night, and every time you have an apnea, that adrenaline surging through your body, racing your heart, raising your blood pressure, all those things are going on. I mean, you're supposed to rest when you sleep.
Right.
And with this marathon going on, that's the connection to heart attack and stroke, right? So you are literally saving a life if you treat sleep apnea. Now, you can argue some people will just snore and it's kind of benign, and you know, if you live to be 65, you probably outlive the chance to die from that. And you won't see death certificates say dead from sleep apnea. You're going to see it say heart attack or stroke. And when do most of those happen? It's in the early morning hours when
Like
we're in
4
that
or
deep
5
sleep.
a.m., right.
We're having the most apnea, and yeah, that's when you have the heart attack, right? So it is a deadly disease for sure.
But if there was another line that said heart attack, you know, and then there was a line that said as a result of,
Yeah.
you know, you might see it then as a contributing factor that actually took place. But we all, as general dentists, love when, you know, you put veneers in someone's mouth and they look in the mirror and they cry. You know, I've had that happen recently, not because they look good, oddly enough, because they didn't look good. But when you've really changed somebody, we did a veneer case recently, and it was a guy, and he was a soft-spoken guy who works here in the building. And when he came to thank me for it, he had tears in his eyes, and it was his birthday, so this was his birthday present. But you know, his smile, people commented to me, say, I never realized, you know, that his smile was bad. And I don't know that it was bad or what bad means, but he's been staring at it every day in the mirror and in his rear view mirror, and this was a huge change for him. I would expect that if you're able to treat patients who have the type of response that your dad did, that you would see some of the same type of response from these oral appliance patients.
And we do, and I take that very seriously. When patients come in, I'm starting to well up now thinking about some of the patients that are so grateful that they have their lives back. They have not just the energy to have their lives go the way they would like. Spouses are happy, their marriages are saved. Literally, you know, people sleep in different rooms and different beds because of snoring and issues like that. And if you can bring them together again, it's a cool thing to do. I mean, they're very, very grateful. And I can't do veneers like you can, but there were a few like that I had, and I see this routinely in patients. They're very grateful, very grateful.
And I know that one of the symptoms of obstructive sleep apnea is daytime sleepiness. And so you've got to think that there's a lot of drowsy drivers out there on the road with undiagnosed sleep apnea who, if you're able to get an appliance or a CPAP and help them, I mean, you're saving lives just through accident prevention in a case like that.
That's right. If you look at Department of Transportation statistics, drowsy drivers cause a lot of crashes and deaths. It's a big deal. And the DOT has a program where they have to test all the drivers and get them into treatment. I mean, just that population is a huge number of oral appliances. They actually have rigs now that can run a alternating current enough to power a CPAP, and they've got that worked out. But oral appliances for sure in that field. But tons of crashes. I mean, other people die, not just you. If you're drowsy driving, it's a serious deal.
So let's say that I'm a general dentist who's got a good restorative practice. My practice has been a little slow for the last 2 years because of the recession, and this is not a theoretical. You know, we saw the lab business slow down a little bit over the last 2 years. So maybe this is a good time to incorporate something new. Maybe you've got a little extra time, like you did when you hung out your shingle, to maybe try something new. It seems to me that a couple of the benefits of incorporating this are, you just hit on one of them, be able to change the lives of patients. There's also that thing of dentists, you know, we all have a couple friends who we went to dental school with who are having back problems, who are either permanently disabled or partially disabled. I remember being jealous, you know, leaning over a patient prepping, you know, 4 or 5 crowns and watching you next door treating a sleep patient because you were standing up and you were taking an appliance and putting in a beaker of hot water and putting it in their mouth and taking out, putting in a beaker of hot water. And I said easier looks like easier work. It seems like it might be less demanding physically if somebody's got, you know, a neck or back impingement, or just to be able to give yourself a break physically from.
It is a nice break from the physical demands of dentistry, which we all know is tough. It's really tough. That DO filling on number 15, yeah, you know, so dentistry takes its toll on your body for sure. I enjoy the break from doing that. I practice half restorative dentistry, so I understand. I love the break of going in and just sitting down and interviewing the patient, talking to them. It's kind of like, being a physician in the sense that you talk to the patient, write a prescription. I mean, this is a hands-on treatment, and it's very enjoyable. We do use our skills as dentists to fit these appliances and manage them. But yeah, it really gives you a nice break from that. And I've got a number of dentists that have told me that they enjoy that break physically.
Yeah, and it seems like fitting the appliance is less demanding than fitting veneers on the margins or fitting gutta percha, right to the apex. It's still fitting it, but it seems like it's on a bigger kind of scale. So it's not, you don't need your loops on, in other words, to do sleep dentistry is what it sounds like.
Right, and it's basically equivalent to 2 or 3 veneers in terms of the reimbursement too. So if you spend an hour and a half, and maybe another half an hour in follow-up, those kind of things, really, it works out to be about as profitable as a quadrant of restorative dentistry, right, per hour. So it's, we expect to make some money for the skill, knowledge, and judgment we have, and you will in sleep apnea treatment.
And I like that you said you end up being reimbursed for the additional appointments where you see for the follow-up, because I think, in dentistry, most of us have had the experience where somebody comes in and they're unhappy with their dentures, and you're like, all right, you rip open your shirt with the big S and you're going to be Superman and do new dentures, and then they're not happy, and then you're seeing them, another 14 appointments, and you realize I'm now losing money on this and I'm married to these dentures. So we can't get paid really for subsequent visits when it comes to that. It's nice to hear that, I guess because of the medical insurance or whatever, that they actually acknowledge, hey, look, you're going to get paid for this follow-up because it needs to be done. Right,
and it's a chronic disease, once again. So, there is a bundling usually of a fee for doing the oral appliance therapy and a certain amount of time where you follow them, but then after that, you do get paid for those follow-ups, and it's just like if you had been diagnosed with hypertension. I mean, you're going to go see the doctor occasionally, adjust dosage. I mean, those office visits are reimbursed.
Right.
So it's the same model that we use.
You're going to be doing some courses for us here at our education center, and dentists can go to glidewellce.com and check out the schedule if they're in the area or want to come out and get an opportunity to see you speak here. After you did your dad's first one and saw, that was a great first one obviously because it got you hooked and you were able to see the potential of what these could do. Once you started treating patients with this, I'm sure you decided, hey, I'd like to be as educated as possible. Today there's a lot of options. Where did you go, or what do you suggest the new dentist who wants to get involved does to get their education level up? Because it sounds like there's a definite body of material that you want to be familiar with as you get started down this road.
Yes, and as you get educated and you understand the medical side of sleep, it brings more enjoyment to the treatment. You understand what's going on, what impact the appliance is having on the airway, the mechanism of things. I mean, when we drill a tooth, we know exactly what the dentin tubule's doing at the moment we pass the burr over. I mean, we don't think about that anymore. But the depth of knowledge brings more enjoyment in the treatment of sleep apnea. And so dentists, you don't need a ton of education, but you want to know the basics. And you can get that in most courses in a couple of days. In a one-day course like we're going to do here, it's sort of an introduction. Here it is, here's the basics of sleep, this is what we do, and a couple of case studies, things like that. So it really gives you a nice introduction to that and a flavor. And then if you enjoy it, then you go forward with maybe a weekend course. And then after that, you've really got enough knowledge to do the treatment. It doesn't require a ton of training.
We've got the, for dentists who find themselves drawn to aesthetics, we have the AACD, for example. Are there dental sleep groups like that, organizations that you can become a member of, or you would suggest that our dentists take a look at?
Yeah, I do. I belong to the American Academy of Dental Sleep Medicine. AADSM.org is their website. I've been in that since its founding, and I love it. I love the camaraderie. When you go to the conventions, we're up to 1,000 members now in that academy. And the meetings we have yearly, the scientific meetings, are awesome. We have speakers from around the world. I actually was a program chair for the last 2 years, and I'm glad that job's over.
I bet.
But just the program is incredible, and once you get going and then you go to this meeting and you see the passion that people have for this field, and you'll just want to learn more and more, and it just adds to the enjoyment.
You know, hearing you speak, it actually does sound a lot like the early days of the AACD, you know, where membership, I remember back when membership was about 1,000 members, and you know, the meetings were some of the most fun meetings you could ever go to. You had a bunch of people who were really excited about dentistry, really excited about what they were doing within their practices that related to this. And this group came together and had a great time and just freely shared information, you know, secrets, techniques, back and forth. And it was this grassroots movement that now has really grown. And it sounds like that's probably where sleep is in terms of dentistry, that you still have the ability to kind of get in on the ground floor and be one of the first dentists in your community to provide this service. You can't do that in many areas of dentistry.
Yeah, you're absolutely right. Dental sleep medicine is in its beginning. Even though you're starting to hear a lot of more advertisement for courses, things like that, we still need a ton of practitioners to do this. And it is in the early days, and it's just like you said, it's very exciting to go to the meetings and listen to, well, I discovered this and that. I had the opportunity to do research, NIH-funded research, the last few years, and sort of become a quasi-researcher. I wasn't trained that way, but they need the dentist to provide the appliances, and so I got sucked into the research side of things, and that's really fun. But I've learned a ton, and there's so much more to learn. The more you learn, the more you know you don't know, sort of like. And so I find the most exciting part for me is that I know there's more to learn.
Right.
And we're going to get better and better at this. We have developed systematic ways for new dentists to just do the treatment, get going. That part's not complicated. It's more along the lines of how is the oral appliance going to impact different types of folks, who is going to work in the best, predicting outcomes for different patients. And that's very important to the physicians, because when the physician makes a referral to the dentist for an oral appliance, they're placing a lot of trust because the physician is really responsible for that patient.
Right.
And so that's the relationship that you have. So the physician doesn't want to make that easily, or will do that without regard for the dentist, right? And so that trust factor, the physician is trusting that you send the patient back, they can be retested with the appliance, because it's not 100%. Oral appliances are at best 60, 70% plus effective in all comers. But as we learn how to select patients better, that percentage is going to go up, and it's become more and more predictable.
Right, which ones it's going to work on.
Yeah.
All right, so if I'm a dentist at home, where do I, well, let me ask you this. One of the objections that I've heard over the years, and I heard it with incorporating orthodontics into the general practice.
Sure.
I hear it, dentists who are interested in CAD/CAM dentistry, but they don't want to get a CEREC unit because they feel it's going to be too much of an intrusion into their practice, to have to mill a unit and then stain and glaze it and put it in the oven. And so I hear dentists say, well, we're just going to do our CEREC chairside restorations on Thursday. Or I remember dentists saying, we're just going to do ortho on Friday.
Yeah.
But the reality is that not all ortho patients can come in on Fridays, and not all people who want one appointment crowns can come in on Thursdays. What's it like to incorporate, say, a couple of sleep procedures a day into a busy general dental practice? Is it a big deal? Do you need to put it all on one day, or?
Well, my recommendation, I've been doing this a long time, and it just flows in my office very well. And I think it can be that way for any dentist that kind of gets into it. But in the beginning, it takes more time. Just like the first time I did a occlusal amalgam prep, it took me an hour and a half, and I made sure everything was perfect, and I was stressed out, and then finally got checked off in dental school, and you're tired just from doing one occlusal amalgam. So it's something like that. When you begin, there's the stress of doing something new, but then you find that it's pretty simple, and complications are rare, and you have to know how to handle objections from the patients. And really, we were speaking about this before, it's kind of a cerebral treatment. It's kind of like more up here than right here in sleep. You get to sit up straight and save your back. It's not physical, but I enjoy the mental part, and you really become more into the patient's lives and understanding what their problems are. And like I said, it's sort of like I take the dental hat off, put the physician hat on for a little while.
Right.
I enjoy the change, but in the beginning, it does require some organization of how to run the appointments. How long is the initial appointment? How long is the workup, the impressions, all that, and then the follow-ups. How many do we need? We have all that worked out in our dentist manual, for example, that we can make available to folks. And so there's a cookbook, but when you begin, nothing's going to fit perfectly. You're going to run into issues, and so you have to allow a little extra time.
That's interesting to hear you say that it's kind of more of an intellectual, I guess, part of dentistry, because I don't know how much of my brain is actually engaged when I'm prepping a crown. I mean, how many times have you done it? How many tens of thousands times have you done it? And I find myself prepping it, looking at the margin, and I just know I want the margin to go closer to the gingiva where that cord is, but I might be thinking of what's for dinner that night or a workout that I'm supposed to be doing that night after work, but it's still kind of an athletic pursuit because it's hand-eye coordination all the time.
Yeah.
And I like the idea of the sleep stuff. Seems almost more like this: talking to a patient, listening, processing the information.
Yeah.
And I think what would scare me as somebody, because when we practiced together, you did all the sleep stuff and I just kind of observed from afar, but I think the thing that would scare me is, okay, what if I deliver one of these appliances and the patient asks a question that I don't know the answer to? It's...
You know what? I love saying I don't know the answer to that.
Because, to a patient?
Yeah.
Awesome.
And it really, it's just total honesty. I don't know the answer to that question. I'll find out for you. You should be totally comfortable saying that. And because this is a new field, and really there's nobody that knows everything.
Right.
I feel like I know a lot, but there's still things I say, well, I don't know.
Right.
I'll find out for you. That's a very interesting question. And patients are fine with that. So getting into it, you really don't have to have that breadth of knowledge. You have the hands, you know how to adjust acrylic and fit an appliance. That part becomes more like the prep.
Right.
We know how to do that. But then when the patient leaves and deciding what appliance to use and how to adjust it, those things require a little bit of thinking, and those things, when you have to think, you get worn out. You know? So as the thinking becomes less, it becomes more and more fun. You're right.
Well, we see it with occlusal guards too. We see a lot of dentists who do 2 or 3 occlusal guards a year, and that's it. But I've heard Dr. Gordon Christensen say that upwards of 60% of people brucks or clench in your practice, and so basically almost 2/3 of your patients should probably be in some sort of appliance. But we don't see dentists, a lot of them anyway, doing a lot of occlusal guards. And it seems like these types of appliances might be the same thing. It's almost like dentists don't consider it real dentistry unless there's a needle and a handpiece involved, and unless some dentin and some enamel is being obliterated and is going to smell like burning collagen in the room. But I think it's nice to have things like ortho and the sleep appliances to be able to have a non-destructive way, in a sense, or to be able to produce revenue in the office without having to go in and do this stuff. And we know patients don't like needles and drills either, so I think it's a fantastic way to be able to interact with them on a level where you're not causing them any pain. In fact, all you're doing is potentially giving them relief.
Yeah, it's really nice that way. 25 years of doing needles and drilling, it's still, when someone's uncomfortable, you feel it.
Right, absolutely.
And so that's strained too. But, if I was going to suggest something to your dentists out there, if they're getting ready to get started, it's really not a hard thing to do. I don't want to paint the picture that you have to have a lot of knowledge or it's going to take a lot of thinking and all that. Really, you just need to get started with an intro course, get a little extra training after you've done a few, and it'll become very simple, and it fits into the general dental practice very, very well. And it won't cause stress. It's going to increase your enjoyment in practicing dentistry. I'm sure about it.
So anybody who memorized the Krebs cycle in dental school is capable of learning what they need to learn.
Yeah.
For
what was that?
dentistry.
ATP, ADP,
Adenal
cyclic, whatever.
Or something like that.
We all knew that stuff at one time, and that's the basis for what we do. Really, we need to know all that as doctors. But in the real life, we need to run a business, and this is a great addition to a dental practice, especially if it's getting a little stale.
Right.
It's really exciting and fun.
So if I want to get started, do I start, let's say I've taken the courses, do I start with my own patient population Do I run a marketing piece for new patients who might suffer from this? Do I go straight to the physicians and tell them what I'm able to offer them? All of the above? Or how do you really kind of get started in this once you've got that knowledge?
Yeah. Well, you mentioned a few minutes ago that, about the number of Bruxers that Gordon Christian said are in the practice. There's just about that many sleep apnea patients in your practice.
Really? So almost 2/3?
Yeah. We did a study, NIH-funded study on prevalence in 2 dental practices, and we did questionnaires. We randomly selected the patients that scored a certain way in a questionnaire and showed that indeed the prevalence of sleep apnea for men in a suburban dental practice in San Diego, where patients aren't really that obese. I mean, there was some hypertension in there. The prevalence is around 60%.
Wow.
And so it's coincidental maybe that it's the same as bruxism, because now we understand that clenching at night, sometimes that's about getting the airway open and breathing better.
Wow, so that may be that. So you're saying the 60% Gordon's talking about and the 60% you found in your study may in fact be the same population.
I find that they're the same patients pretty much all the time. The patients that clench and have TMJ issues, I get a lot of questions about TMJ. What's the appliance going to do to their jaws, to their jaw joints? Those patients that are clenching, of course, they're squeezing the lubrication out of the joint, starts clicking and dysfunction. When you wear an appliance, you're resting the jaw joint.
Right.
You give it rest, you give it space, you put it in a neutral position, and I find the patients with TMJ issues, they get better when I do oral appliance therapy. So all along, many, many years, I was so worried I was going to create TMJ dysfunction. Turns out the opposite is true.
Well, it seems like, yeah, at least from the orthodontists and the TMJ guys that I know, they talk about when somebody comes in acute pain, the best thing you can do for them is immediately get something between their teeth.
Yeah.
Whether it's one of those little aqualizers or something you can put in, get something between their teeth, separate it, and actually if the mandible is being held back, it can slide forward a little bit, and it sounds like you would get some relief on the joints.
Yeah, for sure. But what the point I want to express and make real clear is that the appliances don't create TMD, and that's a false belief that the physicians have. They worry a lot about TMJ because they don't understand it. They're afraid of it. So that's one objection that can be overcome easily. But my statement about prevalence in the practice is true. Those patients are in your practice right now, and they need your help. And if you know what to look for and a few questions to ask, you can find those patients easily. Another way to get going is to acquaint yourself with a sleep lab or a sleep doctor if you have one in town.
How do you find one? How do you find if you have one?
You just open the yellow pages no, I'm just kidding. But the sleep labs are easy to find. You can find them and you just go and introduce yourself to the doc. I tell dentists that ask me, just hat in hand, you're going in, and I'd like to try and help some of the patients that can't do well on the CPAP. I understand there's some patients that can't use it, and I'd like to try and help some of your patients that way.
So you better go in with the knowledge and the recognition that CPAP is the best, is the gold standard, and I'm just here to help those problem cases that you hate, that drive you crazy.
Right.
Yeah, it'd be like somebody coming to us and say, you know what, I want to help you with your post-operative sensitivity crowns on your all-ceramic crowns. You go, you're kidding. I'd love for that. I don't know, do you care how I do it? Not really. Just just get these people out of pain and I'd be happy. So you can actually kind of remove a thorn in their foot by going in the right way.
And you don't need to know a lot. You can go in and say, I don't understand this field very well yet. I would like to have you mentor me as well and learn as I go. And that's the way you start a good relationship. So that's what I encourage dentists to do. A lot of dentists, you can also go to primary care docs and ask them about patients that snore, et cetera. And they don't know what to do with those patients either. What's interesting, sleep apnea is usually not diagnosed immediately. It takes 10 years on average for a patient to be diagnosed. From the time they have some snoring, it gets a little worse, and now, the breathing problems are occurring. Finally, you're tired, and your wife's fed up, and they make you go to the doctor, and now it's been 10 years of damage to your heart and cardiovascular system. So those 10 years, there's a lot of damage occurring. So if you can treat patients early, you're going to offset all those damages that occurred.
It's like getting somebody in a occlusal guard before they grind all their teeth away.
Yeah, pretty much the same thing. So the earlier the better on the treatment. And again, this is not a tough thing to do. It's so easy, so enjoyable for me. There's tons of patients out there. You'll never run out of patients. If you just look in your own practice, you'll find patients. Establish a relationship with a doc. They'll enjoy the relationship too. You go with the, like you said, I'd like to take care of your problems for you.
Right.
And try me out and help me learn this field and partner up.
It seems like a neat opportunity because you're going into, and I don't know what the sleep physicians do when the patient can't tolerate CPAP. I mean, they must just be like, can you try it again for another week? Here's a new mask. And then maybe surgery, which sounds like a pretty radical approach. And then you've got the patient who's probably not all that happy because they're still snoring and they don't feel that good. And you get to come in and go, hey, look, I'm just going to try to, help both of you out. Like you're just coming in with nothing negative, something easy. Are we talking about 2 alginates basically and maybe a bite registration
Basically,
here?
that's it. You have to know how to do a good impression. We all know how to do that. And take a bite record in the proper position for the jaw. There's systems for that are very simple. And you're ready. You're ready to go. You order the appliance. Glidewell has several appliances they make. There's several other appliances that I use that Glidewell doesn't offer, and they all work basically the same way. We're protruding the jaw, we're pulling the tongue out of the way, and it works. It really, really works.
So when you move the lower jaw forward and hold it there, that also moves the tongue and all those muscles forward with it?
Right, and I tell a patient, it's a tractor trailer. When you move the jaw, the tongue's attached and it pulls the tongue forward with it. Because the tongue is what's falling back and blocking the airway. So you pull it forward, or you can blow air in and push the tongue that way. So essentially,
that's what CPAP does, is blows air in and pushes the tongue forward?
That's right.
Okay.
So we're doing the same thing. You got to get the cork out. Move the cork aside, get some air going in and out. It's just 2 different ways of doing the same thing.
Okay. So it's the tongue that is really causing the issue, the cork, if you will, going back over the trachea and not letting the air go in.
It's almost always the case. There's always exceptions like big tonsils and a big fat uvula, maybe. We've all seen those, right?
Right.
So there are exceptions, but most patients have base of tongue obstruction, and if they do, we're going to do well with oral appliances. For a long time, we brought all comers in, did oral appliances on them, and of course some fell out. And we try to figure out why. Why did they fail? These patients do great, these patients get a little effect, and these do nothing. And so we're, like I said before, we're working that out, and we're going to get better and better at selecting the patients. And because the dentist mantra is fail, there's no fail.
Right.
Right. We take it personally if our crown fails or whatever. So in the medical model, what does the physician do? If that drug doesn't work, let's do this one. If that surgery didn't work, okay, here's another surgery. So there's no guilt. You just move forward with the next logical treatment for a patient. And that's foreign to a dentist.
It kind of is, yeah. That's not how we think.
And so you've got to let go of that and say, I'm treating a medical patient. This is the treatment I can offer you. It's the best thing for you right now to try. It may not work.
Right.
And you got to be comfortable with that.
Right. And it fits right in with your I don't know.
Yeah,
I mean,
don't
this
know.
is all just honesty, and they don't expect us to be the superhuman creatures or the being able to make every crown and veneer fit or whatever and not be sensitive. Like we are kind of trained in dentistry with this whole 100 micron margin thing, which is kind of crazy.
And the patients, it's amazing, Mike. The patients don't think the same way about it as they do their crown. Okay. Yeah, it's a medical patient, they have a different attitude. You say, we're going to try this treatment, and they don't expect that it's going to work. You know, if you just say up front, your odds of this working are 70%. 7 times out of 10, this will work beautifully for a person just like you, but 3 times out of 10, it may not. And so you just set the stage, and you have to become comfortable, because you'll fail sometimes.
But they're probably okay with that. Those are great odds in Vegas, at a craps table or horse racing. Those are pretty good odds. Patients wouldn't be as comfortable with, there's a 70% chance this crown will work. And stay on, and that's not the way that we're trained to think either. You mentioned the sleep centers once or twice. Talk to me a little bit about when a patient should go for a sleep study at one of these sleep centers. I know that you've also got, I remember seeing you use some at-home sleep tests where people would bring something home and sleep with this. Is this indicated on every patient that comes into practice? Because it sounds to me like it's pretty important to know whether or not this is annoying snoring or progressive, incurable, chronic, potentially life-threatening sleep apnea.
Yeah, excellent point. So what the new dentist has to understand, that questionnaires are extremely effective at finding these patients.
Really?
So there's some questionnaires that are on the internet that sleep docs use, that physicians use. If you score this way, you have a high level of suspicion, and then you should go for a sleep study. So you use questionnaires first, and then you find the patients, and then you can do several different models of practice. You can then say, I think you should go see the doctor about this problem. I think you have sleep apnea. He'll probably test you. If you have a relationship with that doc, he'll probably send them back if they have the right kind of apnea that oral appliances can address. And so that give and take is always important. Another model would be that the dentist owns a home sleep study device, and they can further screen the patient and test them overnight and say, okay, now we're sure you have sleep apnea. And there are models for the dentist can then get that home study interpreted and by a remote physician, signed off to do an oral appliance. Or then you send them patient off to the lab at that point. They may have severe apnea, and you really don't want those kind of patients. You want to do them a favor and get them to the sleep doc.
Right.
So there's several models, and you can sort of ramp your game up as you learn more and more. I like the model beginning where you just let the doc do all the testing.
Right.
You know, I just let them do everything for you, and then maybe add an oximeter or a very simple device so that you can watch the progression of the apnea go away.
Right.
And then when they're all treated out optimally, then send them for the final sleep study.
But in that first scenario that you mentioned, where you send it out and let the doc do all the work, you just become almost a really highly compensated technician, right? Where he's almost prescribing the appliance with you, and you're going to fabricate it and make it and get paid as much as you are for doing dentistry. But in reality, he's the one kind of managing the case, and you're almost like a dental lab in a sense. You're making an appliance and managing the appliance with the, like physical therapy maybe, while he's got the onus of diagnosis and that burden.
Yeah, and that's true. That's a very important point. I'm glad you brought it up. The dentist is filling a prescription, basically. So the physician is responsible, and the dentist has to have a referral from a doc with a signed order, just like a prescription for a drug. And now you fill that prescription for the patient. So you're really, truly a partner with the doc that way. And so take advantage of that and form that partnership and have a referral base back and forth, and that works out beautifully. But the dentist should not treat a sleep apnea alone.
Right.
I mean, that's just outside the scope of their license to do that.
So the questionnaires that you mentioned that are online, it sounds like they're endorsed by some of the sleep societies. So that having the patients fill those out themselves, it just takes a couple of minutes, I'm guessing?
Oh, it's very quick. While the hygienist is processing, or we don't develop films anymore, but while they're getting the x-rays done and up on the screen, they can fill this out. It literally takes 2 minutes.
Okay. Oh, and every patient, you can just have every patient fill it out for a while and then update it as time goes on. That's the standard of care for kind of differentiating, not snoring, maybe not different, or diagnosing snoring versus sleep apnea, but that's the standard of care for deciding whether or not a patient needs to go a step farther with the sleep study?
Right. On our intake forms, we have a few questions like, do you snore? Has your spouse observed you stop breathing at night? There's 2 or 3 questions. If they check any of those, then they get a formal questionnaire that's validated to detect sleep apnea. And the hygienist will hand them that, and they'll do that. And then the lead-in is for me to come in and say, okay, well, I'm concerned about this. You've scored a certain way on this questionnaire. I have a level of suspicion that you have sleep apnea. And so I'm going to refer you to your physician for further evaluation.
And what's the typical patient response?
They're surprised. They had no idea. And so, the dentist you should feel comfortable giving that information. It's like, we took your blood pressure today and it was high.
Right.
Maybe you should go have that checked. So it should feel very comfortable.
Right.
Because you're really helping the patient out. They may have had this problem for a long time.
Right. Well, you mentioned that it takes 10 years sometimes, and this questionnaire could be the end of that 10-year period. And if you start feeling crappy very slowly over a 10-year period, it's like the old boiling frog thing. I don't think you notice how bad you're starting to feel. And you might be the first one when they fill out that questionnaire to go, look, you scored a 17. this is not normal. You know, most of our patients are down around a 7 or whatever it might be, and I think you're going to really see a significant improvement in the way you feel. You may, it seems like patients might forget what it feels like to feel okay.
Yeah,
they just get used to how they're feeling.
Right, they take it for granted. They're aging, and they just don't think they should feel good, maybe.
Right.
And they can. It's amazing. Even the patients that come in and they say they're not tired. They score a certain way, and they're not sleepy. Then they get treatment. They go like, wow. When I wake up now, I'm not all groggy. I can get up and I'm functional, all day long.
Mm-hmm.
And so they didn't realize how sick they were,
right.
basically. And that's the kind of patient that really is cool when they come back and how you doing? They say, you know what? I'm having the coolest dreams. I haven't dreamed for years. They're getting the REM sleep now,
wow.
rapid eye movement stage sleep. They're dreaming that, like, wow, I had these cool dreams. Hopefully they're good dreams.
Right.
But those are the things that you find, wow, that's cool. Really cool.
That is amazing. And just kind of to sum all that up, it's always fun in dentistry when somebody comes in pain and they leave not in pain.
Yeah.
And we don't get that many endodontically treated teeth where they're just in pain and we open it and drain it and it's like you've released evil spirits from inside the tooth or inside of them. Unfortunately, what we deal with a lot in dentistry is somebody coming in asymptomatic and we say we need to do a crown on this tooth, it's got a big silver filling, and we do it, and then they become symptomatic, and that is part of where that guilt and a lot of the stress in dentistry from postoperative sensitivity comes from. Then you look at these patients, and again, they're coming to you, some in pain, some not realizing how bad they feel, but they're only going to feel better if they get involved with this treatment. So it's almost like taking somebody out of endodontic pain, and what a great ability to be able to do that, and how good that must feel at the end of the day.
And I'm still surprised sometimes by the patients that are chronic pain, headache, fibromyalgia, those chronic pain patients, a lot of them have sleep apnea.
Really? And all the patients dentists want to run from for the most part?
And they're referred to me, so I have to talk to them, right? So I say, God, you've got everything on this questionnaire checked off. Yeah, you're not feeling too well,
They're referred to you, though, for sleep apnea, not for fibromyalgia.
Right. And yeah, they've got all these comorbid problems, and the headaches, especially these temple headaches, those get so much better when you treat sleep apnea because they've been clenching all night long trying to get air. So the headaches get better. By the way, hey, my fibromyalgia is in remission.
Wow.
I'm not kidding. Like, patients get better. They never realize how good they could feel.
Right.
And they just got some sleep.
Right.
They finally got a good night's sleep.
And that makes you a lot more of a hero in their eyes than if you'd taken out an amalgam and replaced it with composite.
Well, I still feel like a hero. You know what?
Yeah, that's not really heroic stuff. This is, just huge quality of life, and it sounds impressive. Now, you showed me recently an appliance that you had a lot to do with, the Apnea Guard. Something that looks to be kind of a trial appliance that helps the dentist, figure out how far open the bite should be and how far forward the jaw should be when we as a laboratory make it as a final appliance, and it gives the patient instantly some relief. When they come in and you diagnose this, they're able to leave, it sounds like that day, with an appliance already instead of waiting a week for a lab to make one. Tell me a little bit about the Apnea Guard.
Yeah, the Apnea Guard, the onus for that was the questions that I get from new dentists starting. How do you do the bite? How do you decide where to put the jaw? How much vertical separation do you need? Is there a simple way to kind of try it to see if the patient's going to respond? And so based on those things, hearing that for many years, we developed the Apnea Guard, which is off the shelf, tear open the package, 2 trays that slide along a sleeve. You put some PVS in there, have them bite into it, and then set their jaw based on an algorithm that we developed. And the patient's treated immediately.
So it's just regular polyvinyl impression material inside of there. They bite into it, it sets, and that's going to lock it onto their teeth.
And it's not going to last a long time, maybe a month. But you will find out if the patient's a responder by using that. So if they're a responder...
Before you commit to the big lab fee. And
Exactly. So you can use it as a trial in that sense. Sleep labs may be able to use that as well, because it really doesn't have to be fitted by a dentist. The Apnea Guard's so simple that a physician, a nurse, anesthesiologist, they can pull that out and fit it to the patient. in the lab, test them in the lab overnight, and say, hey, this thing worked. Make the appliance to fit right where we have their bite, and we know it's going to work there. So it takes some of the mystery out of where does the jaw go? Where should I put it?
Right.
And that's confusing for some dentists. You know, like they adjust it, and all of them are titratable. We call it titration when you make the little adjustments,
Right.
and
To move
the
the
high rack
mandible
screws,
backwards and
yeah,
forwards.
to find that sweet spot. And so we've taken a lot of the mystery out of doing that, made it very simple, and it's low cost. You know, it's going to be inexpensive for the patient and the dentist to try that.
So the sweet spot is we don't want to take them, you know, we don't want to take them all the way out.
Yeah.
If the symptoms would stop when they were only out, you know, halfway or something like that, 50% of the way, 60% of the way, whatever it might be. And it's interesting you bring that up because most of the dentists who send us impressions for appliances will take the impressions and send it with a bite, but it's a centric bite, which is kind of silly because we could have done that on our own with the wear facets.
Yeah.
It's really easy to articulate, you know, full models, and we could have done that, and we're just kind of left guessing how much protrusion they want on this, and so we kind of guess and pick an arbitrary 50% number, but we never get a bite beyond that. And it's sometimes difficult to take protrusive type bites, but this sounds fantastic because they bite into the appliance and then you move the appliance according to this formula.
It just slides, right.
And then you have 30 days to move it where you want, and when it's working for the patient, you take out the inserts and send that to the laboratory, and they make basically a permanent version of the appliance the patient has already worn and gotten used to.
Yeah, that's right. That's exactly right. Good. Yeah, the apnea guard is, you know, taking the bite. You talked about the bite. The apnea guard can be the bite that you send to the lab, like you said. Construction bites, we used to, I remember doing those for functional appliances back in the day when I did that stuff. So taking a functional bite is not hard. We know how to do that, and there's very simple devices you can use they're designed for dental sleep medicine to do that. So really, the bite is very important, and you don't have to go to the maximal jaw position. Almost never do we go way out like that.
Right.
You know, really, you get a logarithmic improvement in the caliber of the airway with just a little bit of protrusion. And in one of the studies we did, I just still blown away by this. Tiny changes, quarter, half a millimeter of titration improve the AHI dramatically. So you never believe that a half a millimeter of moving the jaw forward would impact the patient this much.
Really?
So you need very, very small changes. You don't need to strain the jaw. There's no need to dislocate the jaw and do all that stuff. So that's the cool part. That's what we're still learning.
Right.
That's what makes it exciting because it hasn't been all worked out yet.
Right. That is amazing that a half millimeter, because I guess it's a linear relationship, right? The mandible goes out half a millimeter and the tongue moves a half millimeter.
Well, it's not really exactly like that.
Right.
Because literally what happens as you go forward, the airway dilates sideways.
Oh, on its own. Okay.
We didn't know that until we could have MRI images. And we're like, oh, it's all about moving the tongue forward, and that's what I talk to patients about. But really, it's about increasing the lateral width of the airway.
And that happens when the mandible comes forward as well. Okay.
So the mechanisms of action of the oral appliance is just being worked out too.
Okay, well that makes sense then to have a trial appliance like you're talking about, because like I said, as a laboratory, we just guess where to put the lower jaw. And so maybe we put it someplace and the patient's symptoms go away, but maybe we're 30% farther than we need to be. I would guess that the farther you go out, the more you tend to increase the side effects with these types of appliances and maybe the discomfort of getting used to them.
Yes, that's true. Now, there is what we call a dose effect, just like a drug. The more drug you give, the more response you get. So as the jaw goes forward, yeah, your airway opens more and more and more, but there's a point at which you have diminishing returns.
Oh, really?
Yeah.
Okay.
And so that's what I meant by the sweet spot. You can actually pass up the best position of the jaw. And then there's a vertical component which adds a new dimension to how the appliances work. And the apnea guard has a sort of a system for choosing the amount of vertical for the type of patient you have.
Does that change the shape of the airway with the vertical? Do we understand how
vertical
the vertical
and
affects
protrusion? Yeah, they both do. They're sort of surrogates to each other, and so they both improve caliber. But nobody's really done the MRI studies or CT studies, cone beam studies to look at how the airway changes exactly. We know it gets bigger. Usually it's sideways improvement. of the airway, which is really cool.
Well, again, you're going to be giving some courses for us. Dentists can go to glidewellce.com and check out the calendar, see when you're going to be up here giving your intro to sleep courses. I think it's fantastic. I hope that the people who come to the courses get the opportunity to have an appliance made for themselves, or a significant other, or someone like that, to kind of get them started down this road. It sounds like a fascinating addition to a general dental practice. And you know, a lot of dentists want to be the first one in their community to provide veneers, or the first one to restore implants, or the first one with a CEREC machine, or the first one with a cone beam, and it's getting harder to kind of differentiate yourself like that. You certainly have an Encinitas. You know, anybody I mentioned to in San Diego County or Orange County knows that what you're doing down there with sleep dentistry, so you can have a big impact. You know, you really got involved with the hospital with Scripps right there, and so you're very tight with the whole sleep group over there, which obviously has been a huge relationship as well.
Yeah. Now, one side benefit that I should mention is that when patients are referred by the physician, they often become a dental patient.
Right.
Okay. So if they don't have a dentist, then that works out. I mean, I'm very careful about not taking patients.
Right, just in case they have another dentist already who they're happy with.
Right, and you know, I in that light, you want to act like a specialist. You know, you always send the patient back to the general dentist. But if they don't, then they may become a patient.
Right.
But the relationship with the physicians that I've developed, I mean, they're referring dental patients that don't have sleep apnea. I need a dentist. Okay, I know this guy.
Right.
So, I mean, there is a benefit to spreading yourself out and getting yourself known in the community with the physicians.
Yeah, and the days of I think joining the Kiwanis, you know, to be able to do that, and then all of a sudden, or the Rotary Club, and you're going to have a bunch of people referred to you. That seemed, you know, to work well in the 50s and 60s, and but now this is a new way to kind of integrate yourself into the medical community. And again, you're not saying, hey, I need patients, can you help me? You're saying, hey, some of your patients have problems, and I know you know it because they can't wear the CPAP, and I'm here to help you out. Me, the little old dentist, is here to help out the mighty physician. And I think that's a great story to be able to tell, and a really great way to create some value for them, you know, and get some more patients over.
And you can set yourself apart a little bit that way too. You know?
And then you start buying some Google AdWords, I'm sure, related to sleep and snoring and things like that. And you can see a lot of new patients come. Do you have patients who come to you now who don't get referred by a physician and come to you strictly for the sleep thing?
Not too much. I'll tell you why. Because I mean, I have new dental patients come in and I screen all of them, right? But I don't advertise for patients to come in because when they come in uneducated and know nothing, it takes a lot of time, and the staff time, my time, to explain why they're there, and I feel like I'm selling.
Right.
And that's uncomfortable for me. But when the patient comes from a physician, that's a golden referral. They're there and they're ready to go. I mean, that's it. You got that referral and they're ready. So it takes the discomfort out of trying to sell things.
Right.
When someone comes in for sleep apnea, I'm not selling anything. I'm providing a life-saving service.
Right.
And it feels good to do that.
Right.
So it's not.
They're pre-sold by the physician.
Yeah, they're ready to go. Basically.
They were sold the first time when they got the CPAP, probably, that they have this condition, and now it's just not working, and they're looking to you for a possible easier solution than maybe the CPAP itself.
And when they say an oral appliance, and they know about CPAP, they're real happy to see that.
Yeah. Seriously, I can trade this box that plugs into the wall with this strap-on mask that looks like an alien's on my face, as opposed to these two little occlusal guards that are glued together. These are equal.
Oh, I love it.
And they might, 70% of the time, I'll take it. I'll try it for 70%.
Yeah.
Hope I'm in the 7 to 10.
That's great. I love that part.
That's fantastic. Well, thank you so much for your time today.
All right.
Appreciate you coming down.
Thanks,
and look
Michael.
forward to getting to know a little more about sleep dentistry from you.
Sounds good.
Thanks, Todd.
All right.